Welcome to the Migraine Treatment Guide podcast, where we explore what really causes chronic migraines and headaches and the full range of treatments available today. Each episode breaks down the medical research and real patient experiences to help those living with chronic head pain understand their options and find a path toward lasting relief.
Imagine getting a standard cold or viral illness. You can get the sniffles, maybe a fever, and of course a headache.
Right, the usual symptoms.
Yeah, exactly. And the sniffles clear up in a week or two. You're officially better. But the headache that came with it, it just never leaves.
It just sticks around.
Months or even years later, you still have this sharp, throbbing pain right at the base of your skull. You honestly start to think you've developed some sort of invisible, untreatable neurological condition.
And patients in this situation, they often go through a really torturous cycle. They get labeled with chronic tension headaches or
intractable migraines.
Exactly, intractable migraines. And so they spend a decade trying all these different neurological medications, never realizing the root of the problem isn't actually in their brain chemistry at all.
Which brings us to the core of today's deep dive. We are looking at a completely hidden, entirely mechanical cause for these chronic headaches. Specifically, persistently enlarged lymph nodes that are physically compressing the greater occipital nerve, or the GON.
It's a really fascinating mechanical issue.
It really is. And our information today comes from clinical documentation from headachesurgery.com. We're highlighting the work of Dr. Adam Lowenstein at the Migraine Surgery Specialty Center in Santa Barbara, along with some published surgical case reports.
Some really great source material.
Yeah, and the mission of this deep dive is to understand this hidden mechanical cause of chronic pain and why it goes misdiagnosed for so long. Okay, let's unpack this, because before we can understand why the pain stays, we really have to understand the physical neighborhood where this is happening.
Right. The geography of the neck is everything here. We need to trace the path of the greater occipital nerve. So it originates deep in the neck, right at the second cervical nerve root.
Okay.
And to get to the surface where it actually provides sensation to your scalp, it has to push its way upward through several really dense layers of neck muscle. And it eventually hits a ceiling that it has to punch through. It hits the trapezius fascia, which is this really tough, thick band of connective tissue right at the base of the skull.
Oh, wow.
The nerve literally has to pierce that fascia to fan out across the back of your head. And, it's in this transition zone that the real trouble starts because the nerve isn't traveling alone.
He's got company.
Lots of it. It shares this incredibly tight space with blood vessels, thickened fascia, tight muscles, and a chain of occipital lymph nodes.
And those lymph nodes are basically the body's little immune system outposts, which is where that initial cold or virus enters the story.
Right.
Because if you get sick, maybe an upper respiratory infection or a scalp infection or even mononucleosis from Epstein-Barr.
Or even childhood viruses like rubella or chickenpox.
Yeah, exactly. Those immune outposts, they have to react.
They go to war. The immune cells inside those nodes multiply rapidly to fight off the invader. And that causes the nodes to physically swell. It's a medical process called reactive lymphadenopathy.
Think of this area of the neck like a really narrow, crowded hallway.
Okay.
The nerve is just trying to walk through minding its own business. But suddenly, because of a cold, a lymph node puts on a giant backpack and traps the nerve against the wall.
I love that analogy. It's perfectly accurate. Because in a typical scenario, the infection clears, the immune response dials down, and over 2 to 4 weeks, the swelling resolves.
The node takes the backpack off.
Exactly. It shrinks back down, and the nerve has room to glide freely again. The headache vanishes right along with the cold.
But wait, this is where I get a bit tripped up on the mechanics. A normal swollen lymph node, like when you feel the side of your neck during a sore throat, is pretty soft. It's squishy tissue.
Right. It's very pliable.
So nerves might be small, but how does a soft, squishy immune gland muster enough mechanical force to crush a nerve and cause years of debilitating migraines? I mean, it doesn't seem like it has the density to do that kind of damage.
Well, if the node stayed soft and squishy, it probably wouldn't. But in the subset of patients we're discussing today, the node doesn't just stay enlarged. Its fundamental texture actually changes.
It hardens.
Yes. Over time, for reasons we're actually still studying, the node can become firm, fibrotic, or heavily scarred. The underlying illness is long gone, but the node essentially hardens into a rock.
So the backpack doesn't just stay on, it turns into concrete.
Basically, yes. And since that greater occipital nerve needs to physically glide every time you turn your head, nod, or speak, it's now constantly dragging against a firm mass.
That sounds agonizing.
It really is. Every time you move, or even when the adjacent blood vessel pulses, that stiff fibrotic lymph node grinds against the nerve trunk. And worse, the scar tissue can actually tether the node to the surrounding fascia, anchoring it right in place.
So it's totally trapped.
Exactly. The nerve interprets that constant friction as chronic irritation, so it fires off a continuous stream of sharp, throbbing pain signals. What's fascinating here is that this persistent node doesn't have to be dangerous or cancerous to cause debilitating chronic irritation to the nerve.
Right. It's just completely benign, leftover structural damage from a past immune battle, kind of acting just like a tumor would by occupying space it shouldn't.
Which brings us to the psychological toll of this entire ordeal. Because you have a patient suffering from agonizing daily head pain. Naturally, they go to a neurologist.
They get the standard workup, MRI, CT scans, all of that.
Right. And time again, the doctor looks at those scans and says, good news, everything is clear, your brain looks totally fine.
Man, the patient is left feeling like they're just making it up while this fibrotic node is quietly crushing their nerve. But wait, if standard scans miss this entirely, how does a doctor actually confirm the lymph node is the culprit without just guessing and cutting you open?
Well, we first have to look at how imaging technologies are designed. When a doctor orders an MRI for severe chronic head pain, the radiologist is hunting for dangerous red flags.
Like brain tumors or aneurysms.
Exactly. Active disease processes. Standard imaging is highly optimized to catch pathology.
So they aren't looking at the millimeter by millimeter spacing in the neck tissue.
They aren't. Think about the resolution of an MRI. A typical scan might take image slices that are 3 to 5 millimeters apart. The greater occipital nerve is only about 2 millimeters thick.
Oh, wow.
And the enlarged lymph node might only be 1 centimeter across. It's entirely possible for the slice to capture the node but completely miss the exact point of compression on the nerve.
And a benign node wouldn't look like cancer anyway, right?
Right. It just looks like a slightly prominent but otherwise normal anatomical structure. The scan gets stamped as normal.
So neither the patient nor the doctor connects today's headache to an infection from years ago.
Right. The timeline is so disconnected. A neurologist will ask about family history, stress, diet. They don't typically ask, hey, did you happen to have a rough bout of Epstein-Barr virus 3 years ago, right before the headache started?
So we're stuck in a diagnostic blind spot. How do you actually prove the nerve is trapped?
You shift away from imaging. The actual diagnostic path relies on symptom mapping and a diagnostic greater occipital nerve block.
A nerve block. So they inject a local anesthetic, like what they use at the dentist, but at the base of the skull.
That is the exact mechanism. The physician injects numbing medication directly into the tissue surrounding the greater occipital nerve, right at the suspected compression site.
Just to see if the headache temporarily turns off.
Exactly. It is purely an information-gathering mission.
It's like finding a kink in a long garden hose. If you patch the hose near the nozzle and the water suddenly flows fine, you know the problem isn't all the way back at the faucet.
That's a great way to put it. If the patient gets significant temporary relief from that block, even if it only lasts for a few hours, it proves the compression is peripheral.
Meaning it's right there at the skull base rather than closer to the spine or in the brain.
Right. And from there, a physical exam can often identify the firm, palpable node. The doctor can physically feel the trap with their hands.
Because it's hard and fibrotic now.
Exactly. This raises an important question about how we differentiate between a normal sick node and a chronic compressive one.
That's a crucial distinction, especially for anyone listening who might be poking the back of their own neck right now.
Oh, definitely. The sources highlight the timeline and the pain pattern. A self-limited normal node swells for a few weeks and gradually softens.
Then it goes away.
Right. A compressive node remains enlarged, doesn't shrink, and hardens over months or years. And the pain is different too.
Mild diffuse tenderness versus chronic sharp throbbing pain, right?
Exactly. It behaves like localized nerve damage, not just a swollen gland.
Here's where it gets really interesting. Moving from theory and diagnosis to actual physical proof. Because headachesurgery.com actually features a gallery of intraoperative photographs.
Yes, from the actual nerve decompression surgeries.
Right. These photos physically document lymph nodes sitting directly on the GON trunk, visibly compressing it. You can see it.
It stops being this abstract neurological condition when you look at those images. You can visibly see the physical indentation on the nerve where this mass has been crushing it for years.
Just sitting there, totally validating everything the patient has been feeling. And the expert brings in a specific striking case from these files that I found incredible.
You mean the tag team scenario?
Yeah. A patient where a lymph node and a compressive blood vessel were tag-teaming the same nerve.
It was the ultimate crowded hallway. But during the procedure, the surgeon excised the scarred lymph node and managed the blood vessel.
Removing both of them.
Yes, taking all the pressure off. And it led to a marked reduction in her headaches and the complete resolution of the visual disturbances and nausea that accompanied her migraines.
That's amazing. And there's outside validation too, right?
There is. The documentation references a 2011 case report published in the Journal of Plastic, Reconstructive, and Aesthetic Surgery by CEO and colleagues.
Okay, so a totally separate study.
Exactly. Now, this documented a reactively enlarged node compressing the lesser occipital nerve rather than the greater, but it proves the exact same underlying principle.
That an old illness can leave behind a mechanical, correctable source of migraines.
Right. The treatment is excision. The surgeon carefully exposes the nerve and removes the offending node and fibrous tissue to create space.
What does this all mean? We often think of chronic migraines as an invisible, untreatable neurological curse.
A lot of people feel like it's just a chemical imbalance they have to live with.
But sometimes it's just leftover scaffolding from a cold you beat 3 years ago. So, if you are listening to this and you've had a headache that set up shop after an illness and never left, it's worth considering mechanical compression.
Absolutely. You have to advocate for yourself. If traditional neurological treatments are failing, ask about a diagnostic nerve block.
Right. Which leaves you with a final, lingering question to chew on. If our own immune system's leftover debris can cause years of excruciating, misdiagnosed pain simply by pressing on a nerve in the neck.
It's a wild thought.
It really is. It makes you wonder how many other chronic, unexplained conditions in our bodies are just simple mechanical traffic jams that our advanced medical imaging isn't designed to see.
That's all for today's episode. Thank you for listening. If you or someone you love is living with chronic headaches or migraines and hasn't found relief through medication or other treatments, know that outpatient surgical options exist for chronic migraine, occipital neuralgia, and other headache diagnoses. To learn more or schedule a consultation, call Dr. Lowenstein's office at 805-969-9004 or visit headachesurgery.com. Please don't forget to rate our podcasts so others can find us and learn about chronic headache relief options. Thanks again for tuning in, and we'll see you next time.